This is a video abstract for the review article that we have published in the Heart talking about the TAVR. What I want to ask Shikhar, who has put this wonderful review together, is talk about how we analyzed the different data and how we put this review together, with including what kind of data set from different registries.
Sure. So TAVR has emerged as an attractive alternative to conventional surgical aortic valve replacement for high-risk as well as inoperable patients. We have used non-randomized and randomized controlled trials in our review and looked at major results out of these studies. We have used these studies to review important implications for patient selection, risk assessment, important procedural aspects, as well as factors important for post-procedural care. In addition, our review focuses on some of the novel aspects for TAVR, including use of TAVR for bicuspid aortic valves, pure aortic insufficiency, valve-in-valve implantation, as well as implantation of TAVR for low-gradient, low-flow aortic stenosis.
That is excellent, and you have already put in different figures and tables all the information, so that is easier for the people to read, and that is very well presented.
Absolutely, absolutely.
The main finding of the TAVR, if you were to summarize in 5 points, the 30-day mortality from transfemoral and transapical TAVR in the world ranges from anywhere from 3 to 6%. If you look at the stroke risk is about 1.5 to 3.5% at 30 days in the different registries. And the stroke risk is a little bit higher when systematically studied, meaning that the self-reported registries may underestimate the risk of stroke. And compared to the surgery, the stroke risk was particularly higher in the partner studies, and in the Corval recent trial, the stroke risk with surgery was slightly higher. So again, there is some controversy as to what the TAVR stroke risk is. The very important other limitation of the TAVR that we have identified is the paravalvular leak, and with the newer valves, this problem is getting less. However, the paravalvular leak is a very important problem and is associated with higher mortality in these patients. And then finally, a lot of different indications of the TAVR are changing, because initially we started with inoperable patients, then we went to high-risk patients, and the intermediate risk patients and the low-risk patients are under investigation. The low-risk patients, there are no trials, but the intermediate risk, the trials are completed or in progress, and very soon we will see the results, maybe in a year or two coming up. I have with me Dr. Tuzcu and Dr. Svensson, who are the leaders in the TAVR from Cleveland Clinic. I want to ask Dr. Tuzcu a little bit about the future and the current ways of selecting different valves and what the new valves will bring to us, because it's very clear that the newer valves are becoming available, and it is no longer a futuristic idea, because in Europe there are almost 10 valves available.
Well, the shortcomings of the currently available valves are, as you said, paravalvular aortic regurgitation, repositionability are the two main things. So there are now new generation valves of both the Edwards Life Sciences company as well as the Medtronic core valve, that is the S3 and then Evolute respectively, that try to address this issue of, in Edwards, much less aortic regurgitation, which makes us very happy, and in Evolute, repositionability and easier positioning and hopefully less AR. But there are also brand new valves that are new designs, very out-of-the-box thinking. There is direct flow that doesn't have any metal in it, and it has 2 rings, and it really is wonderful for reducing aortic regurgitation and ease of implantation. There is Portico, a self-expanding valve that also has decreased rate of paravalvular regurgitation. Very innovative technology of Lotus valve, that is Boston Scientific is working very hard to get it. It's already in clinical trials in the United States, and that also is repositionable and then reduces the aortic regurgitation. So in addition to these valves, there's Jena valve that's in the United States that is, I think, that Very innovative idea, and looks like that it will be very suitable for aortic regurgitation, pure aortic regurgitation cases with large annulus, because it sits right snugly with the leaflets. So I think that future is very bright, and the industry is responding. Investigators are very excited, so we're looking forward to that.
You think that there is any difference how people will select the valves is dependent on different characteristics of the valves, different sizes?
That's right. There is no doubt that if you have a minimally calcified aortic annulus with fairly large and aortic regurgitation is the predominant lesion, you won't want to go with a balloon expandable stent, but perhaps a self-expanding stent such as core valve will be, or Jena valve will be better. I think that if AR is very important for you, maybe you will choose the direct flow or the Lotus valve that's in a very thick ventricle, small ventricle. And I can go on and on like this. But I think that another important thing is the expertise that the operators will develop in a certain valve. So I don't expect everybody to have 6 valves on their shelves.
Excellent. And now I want to ask Dr. Svensson. Dr. Svensson has dedicated an entire career to the aortic valve surgery, aortic surgery, and now the transcatheter aortic valve. So you have the whole breadth of experience about the aortic pathologies. The question is that how you see this valve implanted in different alternative access. What is the importance? How you see the future of alternative access rather than the transfemoral access, because a lot of patients require this, and how the field is evolving in your opinion.
So, Samir, as you know, we were involved in the original animal research with the transapical approach, and that's still the approach we use for the patients who have had previous cardiac surgery. And about a third of our patients still need alternative accesses. So for reoperations, we use the transapical approach. We've done about 200 patients, and our mortality rate, 30-day mortality rate for that is 1.3%. The other alternatives is the keyhole mini-invasive operation, something that we describe for the J incision. And we've done about 100 patients that way. So those are primary cases, not previous surgery. Then we've got the patients really high risk, typically on multiple liters of oxygen. We can use then a carotid or a subclavian approach. And we've used those too. And I think one balances out the comorbid disease, what patients have had previously, as to which way you're going to do it. I would say, well, one thing about keeping in touch with doing the transapical approach is now as we get more and more of the mitral valve procedures, that's primarily initially certainly going to be a transapical approach, and with our expertise on handling the left ventricular apex, I think we're ready to do that. And as you know, we've already done a number of valve and valves in the mitral valve and also in the tricuspid valve. So I see we're going to all work together, and it will be like all things in surgery. You have a broad armamentarium approaches to handle different problems in different patients, and you select what works best for the individual patients.
No, that is excellent. And one last question about the low-risk patients and intermediate-risk patients. What would you like to see the transcatheter valve? When can we really move to a lower risk
So
population?
I think the big barrier up to now has been the perivalvular leak, but that's getting less, as Murat mentioned. But I think there are also the issues of stroke. In the partner trial, the transfemoral stroke rate was 3 times higher than open. And so the filter devices are going to have to come into play to bring that down. Our mortality rate consistently has run between 0.4%, 0.7% for all comers, including endocarditis and reoperations. That's the standard that these new percutaneous valves, as far as I'm concerned, need to get down to, and a stroke rate in the region of about 1%. Then I think we can begin to talk about the intermediate risk patients and the best approach for patients.
And I think that is what is the bottom line, is that if you have a great team, and if you have a team approach, as we point out in our review article, that patient selection is not dependent on one individual, but entire array of options should be available, should be discussed with cardiac surgery, cardiologists, imaging people, anesthesiologists, and patient and family. And all together, if they make the right decision for the patient, this would be the future